Thank you, Mike. Thanks, Ali, for inviting me to give this. It's a little bit tough following on the heels of four or five of the most innovative young surgeons out there. Tony, I lump you in with the young surgeons as well. But I'll try to give maybe just a little overview, a little philosophical. I think a lot of this has already been covered, so it maybe scoot by some, so we'll have some time for questions. So my disclosures, part of my job in Strasbourg is dealing with companies, so I do have the pleasure to work with industry a great deal. And of course, always the disclosure about anybody that has a gumption to talk about the future. It's obviously an impossible thing to do, but I'll do my best. So I'm going to give you three, of all the infinite things I could talk about, I'll talk about three things that I think maybe are general trends in surgery that we'll see developing over the next 1 or 2 decades. And the first one is that everything's about minimally invasive surgery. So nobody's going to go back to maximally invasive. So it doesn't really matter if a randomized study showed that open cholecystectomy was better than laparoscopic cholecystectomy. Nobody's going to go back and have an open. If you think about lap chole, common duct injury rates 3 times what it is with laparoscopy, but nobody will have open surgery. So everything in the future will have to be less and less invasive. I like to kind of look at surgery in different clumps. It's kind of an interesting timeline if you draw that out, and really from the Middle Ages or even from Egypt and Greece up to the 1800s was an age of just discovering pathology. There wasn't anything you could do about diseases, but it was a great diagnostics, pathology, and anatomy discoveries of that. And only around 1900 did you ever have a chance of operating on somebody and not having them die from the surgery. And that was the age of cure. And obviously, at that time, you opened them from stem to stern, you did thoracoabdominal incisions. You didn't really care if they were totally disabled and miserable after your intervention. You were just proud that you could actually surgically intervene in a disease and cure it. We exist, and SAGES and other societies and everybody in this room exists in the era of patient-centered care. So what happened in the 1990s and 1987 with the introduction of laparoscopy wasn't a magic scope or 2D visualization or anything like that. It was that what the patient wanted came first for the first time. So surgeons had to start caring that how we intervene in the patient makes a big difference. So if the patients don't like it, patients didn't care less, as Mike and I can attest, to having their gallbladders removed from their vagina. They just didn't care, and so it's not going to happen. So it has to matter to the patients. So this is really the era of patient-centered surgery. And I think when we think about that, we think about standard flexible endoscopy, we think about things like ESD and certainly laparoscopy, but there's so much more that fits into this category, and this is really where future evolution in surgery is going to happen. This is organ-sparing surgery. Nobody wants to have their entire esophagus taken out or 3 feet of their colon taken out when the disease is 2 centimeters. Cellular targeted cancer therapies, natural orifice surgeries where there's no scar, no deformation of the body, image-guided surgeries, and perhaps robotics. I think one of the biggest trends we're going to see is what's been called individually targeted therapies or patient care that revolves around giving the patient power to make their own diagnosis and the power to take care of themselves after an intervention. And this will be things like implantable monitors and wearable diagnostics and at-home diagnostics. And I don't have time to talk a lot about that, but I think this is something that surgeons are going to have to start thinking more and more about because in the future, you'll probably not be taking care of patients in a hospital, but in an outpatient facility, implanting some sort of monitor that will talk to your cell phone that tells you when they're at risk of having a complication or not. And I think the other big thing that we'll see is more and more hybrid interventions. And Professor Peretta mentioned this, where we work in Strasbourg is very big at taking the best of the world of flexible endoscopy, the best of the world of laparoscopic surgery and the best of the world of interventional driven interventions, and combining those to really have targeted, individually sculpted surgical therapies that maybe don't need the skills of a surgeon altogether, don't need the skills of a radiologist or a flexible endoscopist, but need a little bit from each of those disciplines. So more and more you're going to see individualized training pathways, individualized practitioners that are targeted on the disease more than on the technology. And I think surgeons often don't stop to think how really we think of flexible endoscopy or laparoscopy as the pinnacle of minimally invasiveness, but really interventional radiology is much less invasive. Percutaneous access and percutaneous surgery is probably in many regards one of the least invasive, and certainly things like the gamma knife where there's no perforations of the patient and where it's totally pain-free is the ultimate in non-invasive surgical therapies. So you can kill tumors, you can excise tumors, ablate them without even making an incision. So one of the things I always remind surgeons is, yes, we talk a lot about you need to learn flexible endoscopy, we talk a lot about how do we get people up to speed in laparoscopy, but we can't forget interventional radiology, because in some regards this is the least invasive technology that we have overall. Second point I want to stress is that the world that we deal with is changing, and this is particularly true in digestive cancers. And more over the next 20 years, we're going to see a disappearing role for traditional surgery in taking care of digestive cancers. How do I know that? Well, if you just look at population-based trends, we know that even though cancer is increasing with environmental contaminations and patients living longer, cancer deaths are dramatically falling and have fallen by and large. And this is not because of surgery. This is improved chemotherapy, it's improved screening, it's early interventions that really have led to that. And I think one of the biggest things that we'll be seeing is more and more sophisticated screening methods, and this is going to mean that the end product, what surgeons see, are going to be earlier and earlier cancers and even pre-cancers that we'll be asked to deal with. And these are particularly amenable to minimally invasive therapies. So there's a huge world of research that we seldom hear about in early cancer detection and screening methods. So now we think of colonoscopy, upper endoscopy as a screening method, but soon it's going to be DNA-based things, it's going to be optical screening, it's going to be swallowable capsules, it's going to be stool testing, it's going to be genetic profiling, it's going to be somebody in your Costco having a transnasal 2-millimeter scope that you run down and they can diagnose your Barrett's esophagus in the matter of minutes. So this is the future that's going to be driving the kind of patients that we see in the future. Why is this important? Well, if you see early cancers, they're perfectly suited to taking care of them with a minimally invasive or non-invasive fashion. So we know now that we treat Barrett's with radiofrequency ablation and spare a patient esophagectomy. We know that we treat early gastric cancers by ESD, a nice en bloc surgical resection, and the patient goes home the next day and they go back to work in 48 hours. We also know, as I mentioned, based on population trends, we see what's happening in Asia where they have an active foregut cancer screening national programs. And 5 years ago, the line crossed where there's more esophageal and gastric cancers in Japan and Korea that are treated by flexible endoscopy than there are by surgery. So these are diagnosed cancers. The majority of them are treated by flexible endoscopy. So undoubtedly, we'll continue to see that in the United States. It's important from a social standpoint as well. This is actually data from our hospital, our health system in Portland, but you can see the tremendous difference in cost and expense when you treat somebody with an endoscopic treatment, in this case it was early esophageal cancers, versus minimally invasive surgical laparoscopic procedure, 10 times the cost difference. So very important in this day and age. The third thing I'll briefly mention, because Silvana did such a good job covering this, was the importance of how we see, not just seeing, giving up our palpation techniques and stuff and focusing on visual aided things, but how we see that is going to be increasingly important. And this is tremendously evolving. This is contaminated, if you will, by the evolution in computers, which, as you know, exponentially advances because it's such a critical part of our society. I think this opens the door to patient-specific preoperative imaging. This is going to be there's probably no radiologist in the audience, but I suspect over the next 10, 20 years, radiology is increasingly going to be taken out of the hands of the radiologists and put in the hands of the surgeons. Once images are useful to surgeons, you don't really need a radiologist to tell you. So if you have a 3D image that you can manipulate yourself, you don't really care what the radiologist says about it, because you can look at it yourself and base your surgical decisions on that. So we're going to see a decreasing role. Radiologists, of course, will they'll read those screening x-rays, they'll do the screening things and do the diagnostic, but therapeutic, all this evolution in imaging and image manipulation will put the power of that radiology back in the hands of the surgeon and really take it out of the hands of the radiologist. So prepare yourself for some interesting turf wars in the time ahead. I think 3D printing is going to revolutionize how we do surgery. It's already very popular to 3D print organs so that you can actually handle it and see what it looks like. You can do that either virtually as simulation, as you heard about, but you can also do a physical model. You can do a physical model for a patient-specific thing, so you can actually look at the patient's pancreas and see where their tumor is, make it in plastic so you can cut it in different ways and see how it would work, and you can do it by simulation, as you heard. And fluorescent guided surgery that Silvana talked about is going to be critical, and I predict that within 2 or 3 years, every single laparoscopic light source that you have in your operating room will have near-infrared capabilities automatically built in. You won't even be asked if you want it or not. It'll just be there. And that this will be a very important endeavor for ischemia, for tumor identification, and maybe most importantly, to decrease surgical errors and complications. So this can really augment how we see and give us an extra margin of safety for patients, saving money, saving patient harm, and once again, just doing a better job overall. This is a tremendously popular field. It's growing quite rapidly. There's a new society that was just formed for fluorescent-guided surgery. Finally, I'll just mention robots. Dr. Linikov kind of covered this pretty nicely, so I'm not going to talk a little bit about it. Just give you a little bit of my own bias and let you know that there's 20 robotic companies out there on the horizon that are going to really blow this wide open. So competition is coming to the field, and I think we're all looking forward to that. And so you're going to see a lot of new platforms out there. I think the day of the $2 million robot is probably limited. It's just limited by the fact that medicine has no more money in it. And if robots are important for surgery, you have to have 20 or 30 of them to fill your operating rooms, and nobody can do that at $2 million a pop. I think it's really time right now. It's a good time to really deconstruct the robotic field and figure out what surgeons really need or really want or can use from robots. And this is kind of a list of all the things you'd hear from somebody that does robotic surgery that they like about Da Vinci or other robotic platforms. And there's no doubt that these are good things. I think the real question is, can you get those in a cheaper and more economic fashion? And 3D imaging is great, as I'm finding out lately. But that's available now laparoscopically. Most major imaging companies make 3D laparoscopes, so if you want 3D imaging, you can run out and buy that off the shelf today. And I think it's very fascinating if you look at what you like about the Da Vinci. It's the 3D imaging, but it's also the wristed instruments. And there's some very innovative companies now making standard laparoscopic 5mm instruments that have the same degree of freedom as the Da Vinci and are many, many hundreds of times less expensive than that. So wristed instruments don't necessarily need a major platform and can be available with hand instruments as well. Ergonomics are important, but maybe you don't need a whole robotic platform. One of my colleagues, Joël Leroy, just likes to sit on a chair, and he looks very comfortable doing that. So maybe there's easier ways that we can achieve that. And maybe the robotic suite of the future looks more like this than it does a Da Vinci platform, with a comfortable surgeon sitting on a platform looking at a 3D laparoscope and using a robotic enabled laparoscopic instrumentations without a full platform. And then Dan kind of covered a lot of this, and so I'm not going to talk a lot about it. I totally agree with him that endoscopic approaches to most of the benign diseases are mandatory because it's so much less invasive than that. He didn't mention one device, and just if you're a bariatric surgeon in the audience, just to kind of shake you up a little bit, I can tell you that the single most effective bariatric procedure ever described in the literature is an endoscopic procedure that's done under sedation, takes 12 minutes to do it, and is around $4,000. And it beats hands down any surgical procedure ever done. And that's the simple stent. This is a little bit tongue-in-cheek because there's only a single trial, but they had to stop the trial because the patients lost 100% of their excess body weight and wouldn't stop losing it, and they had to take the device out. So they're reconfiguring the device. But this is now in European trials, and it's the full stent. So it's 75% excess body weight loss in the short version, and they had to pull many of the devices out. And we think in SAGES in particular that lap chole is the ultimate way of taking care of the gallbladder. I think many laparoscopic surgeons breathed a sigh of relief when Notes cholecystectomy didn't progress. But I can tell you there's a lot of interest in still a less invasive way of taking care of gallbladder disease. And this is a transluminal stent that can be easily placed between the duodenum and the gallbladder with EUS, creating a fistula where you can go in and take out the stones, ablate the gallbladder mucosa, pull it out, and it would be a quick and easy and very non-invasive way of taking care of gallbladder disease. And actually that's a procedure that's being clinically done today and is spreading like wildfire across the world. So in conclusion, I just say technology is advancing. We tend to follow rapidly in our applications as the technologies become available. So when laparoscopic staplers were available, we started doing laparoscopic colectomy. And when these new technologies become available, we'll start pushing the boundaries of this less and less invasive. So I think the important message for surgeons is to stay flexible, to keep an open mind, to look at the data, but when these things make sense and your patients ask for them, you need to go out and learn it. Thank you very much.